Hi there everyone, it's Sarah from BJC Health here. Thank you so much for all of your support over the years in this YouTube channel. We're continuing to look forward to bringing you more content that can help you live and feel that little bit better. So this webinar or workshop was all about methotrexate. And so that's a very common drug that's often, or medication that's used within the realm of rheumatology. I guess when watching this, please remember we're based in Australia. Our rheumatologists are definitely speaking about the use of methotrexate in an Australian context, but hopefully you still find the video useful. And if you do find it helpful, then please like and share it with anyone else you think would feel the same way. But enjoy and look forward to seeing you soon. Evening, everybody. Thank you so much and welcome to tonight's event. Good to see some familiar faces. I think some of you have got a full hit rate now of these lifestyle events, which is great. So welcome once again. So I'm Sarah, and tonight Irwin will again be facilitating most of the discussion. So just some housekeeping. Most of you are pros, but just in case this is your first event, we do mute everyone when you come in, and if you can stay muted for the majority of the session, that would be great, just so everyone can hear Irwin clearly. We are recording the sessions now, so just to make sure they're available for those that aren't able to attend, and we'll also share it with yourselves as well in case you want to listen to it again. We'll be using the chat feature, so if you do have questions, so Irwin's assured us that there's lots of opportunities for questions tonight, so we'll encourage you to use the chat, and potentially at the right moment, if you want to unmute yourself to ask the question, that's cool too. So with that, any further ado, welcome Irwin. We're looking forward to tonight's discussion. I think he's looking forward to it, but I'm sure we'll all learn some good nuggets. So thanks Irwin, and welcome again everyone.
Hi everyone. Thanks for kind of spending your Wednesday night with us again.
It's a female medication.
A what, sorry?
A female medication.
You might need to mute yourself, whoever you are, to help us out. So when we were putting together the list of topics, I decided that methotrexate would be the very first medication related one. And that's because there's a little bit of a love-hate relationship with methotrexate among most of the patients that I treat. And there's many good reasons for it. And today I'm hoping we explore this. I've titled this Myths and Realities. I want to really be very frank with you, and I want to give you a perspective as to why rheumatologists use this drug so much and why you might hear such conflicting views. Okay, many of you are patients of the clinic, so you know that I'm the director, one of the directors I should say, of a multidisciplinary group clinic, and we've got lots of staff here, and our whole aim, and one of the reasons why we're doing these talks, is that we want to change the lives of people who have rheumatic diseases. And we do recognize that there's only so much we can achieve in the realms of a rheumatology consulting room, which is why these events kind of have come to light. Some of you have already seen this picture. I like this picture because it's a typical case for me. And so this is a female who presents with 6 months of intermittent symptoms affecting her wrists and her hands. And in this particular case, the diagnosis is not in doubt. It's rheumatoid arthritis. It's quite a clear pattern. This patient, who's actually based on a real patient, had very typical symptoms, and she had a very good GP who thought of the disease, did the appropriate blood test, and she has a high-level anti-CCP. I'm sure some of you will be aware that anti-CCP, either in yourselves or in your spouse, might be high, and this is a very, very specific test for rheumatoid arthritis. So the GP wasted no time, contacted us, and we saw the patient. Now, the problem, and let me put this in perspective. So in this particular female, she's in her mid-40s. She's already had 3 children. It was easier to choose the medicine. And the medicine that I think the vast majority of rheumatologists around the world would give in this particular scenario, where you have seropositive rheumatoid arthritis, meaning the antibodies are positive, would be methotrexate. Okay? And this is the drug that so many people don't like. And part of the problem is the name. Right? You can see it there, methylblastin. When they first started to use this drug in the 80s, they really should have thought of a better name, because I think it puts a lot of people off. To start this off, to give me a bit of an idea about the crowd tonight, I have my first poll here, and let me, hopefully I can make this work. I'm going to relaunch the poll. And what I'm hoping is that you can actually see a poll in front of you. I'm actually going to give you all a chance to answer because I want to understand how I should pitch tonight. So I can see that 34 of the 48 of, okay, we've got 50 here and 37 unanswered. I might, oh, the numbers keep going up. So I might give you another 10 seconds or so, and then I'm going to end the poll. So please, okay, I won't drag it on. Let me just end the poll now, and let me share with you the results. So the majority on tonight are on methotrexate currently. Some of you have never been prescribed it, and so I'm curious why you're here. You might be interested or you've read about it. And of course, everyone else has used methotrexate in the past. It's interesting that only one person said that they were prescribed methotrexate but never used it. Because as a registrar about 18 years ago, one of my projects at Westmead Hospital was to review the number of people on methotrexate at a very busy consultant's room. And it worked out that there were about 10% of people who were given a script for methotrexate who just never came back. So we assumed they never bothered using it. Okay, so let me get back to it. Okay. Now, I've got a second poll because it follows on from what we've just talked about. And again, let me share this with you because it will again help all of us understand who's on this call and help me appropriately pitch it. So this is the second poll. And so if you were prescribed methotrexate, and I think there were 30-something of you who owned up to it, can you tell me roughly what the diagnosis might be? This is all anonymous, so we won't actually have any kind of identifying data. Again, I'll give you another maybe 10 seconds. Most of you have answered, I think. Okay, I'm going to end the poll and share this with you. Okay, so 40-odd%, 39% have rheumatoid arthritis, psoriatic arthritis, seronegative. So there's a bit of a kind of a smattering of different conditions. And I did this on purpose because when we talk about methotrexate, rheumatologists, by far the number one reason why we use it will be rheumatoid arthritis. And that's because of the data for its use. But it's clearly used in a whole bunch of other diseases. With psoriatic arthritis, most of the treatments for psoriatic arthritis until the last, I suppose, 10 years or so were all based on rheumatoid arthritis. So it was a bit of a poor cousin. So anything that worked in rheumatoid arthritis would be trialed in psoriatic arthritis, even though it tends, at least for methotrexate, the data for its effect and its usefulness is definitely lower than in rheumatoid arthritis. I on purpose put in this seronegative inflammatory arthritis / spondyloarthritis group. This is a more vague group where you don't fit the classic patterns of rheumatoid arthritis and psoriatic arthritis. That's not to say that it's not a real disease or that it's not serious. In fact, it can be very hard to treat and very frustrating. And so this is another group where we use methotrexate. Now, one person here is having methotrexate for either PMR or giant cell arthritis, and Sjogren's and vasculitis. And what I want to say as a whole for autoimmune diseases is that all of these autoimmune diseases are treated with steroid. Okay, and invariably, those of you who are on methotrexate for these diseases have already been on steroid, and the methotrexate is often used as a steroid-sparing agent to help us reduce the dependence on prednisone. Okay, so that's the main reason for these diseases. Okay, I'm gonna stop sharing and let me just get on with this for a little while. So again, I think I told you last time I like this picture because it always reminds me to think about the effect of the patient when they leave my room. And methotrexate seems to incite a lot of these sorts of feelings. And often people go home, they talk to their partners, they talk to the pharmacist, they talk to a neighbor who happens to be a nurse, and they hear all sorts of things about methotrexate. So I'm just mindful that there's quite a bad community vibe about this medicine. So why might that be? And I think there's clearly a disconnect between what the doctor, the prescriber, is saying and what people are hearing. And it's actually on us as prescribers to actually understand what people are going to hear. And so for those of you who are my patients, you usually have a spiel from me about methotrexate. And there's clearly this community perception about it, which is based on the fact that methotrexate started in the 70s as chemotherapy, okay? And it started as chemotherapy for breast cancer as well as leukemia. But in those diseases, it's given in grams daily by drip or through the spine, okay? And that's why it's been called chemo. And I think also at the start of its use in the 80s, when doctors first started it, we were all very cautious in how people, were being, and how methotrexate was being used. And the word chemotherapy was used a lot at that stage to describe this drug, which of course is not being used in therapeutic doses when we use it for the conditions I just listed. In fact, for most of you on this call, the dose would be, starting at around 10 to 20 milligrams once a week. And the analogy I tend to use for my own patients is that if you had a headache and I gave you 2 Panadol, you'd happily take it. But if I told you to take 500 Panadol, you'd look at me funny, right? So that's the analogy I'm going to give you with the chemotherapeutic doses of methotrexate versus what we actually use for these diseases. Okay. So I use this slide as well to remind me to just pause. And I'm very happy to take some questions. I still have a few slides, but tonight's really to answer a load of your questions. So feel free to start on the chat, and I'm very happy to try to address things. I think Michelle sent me a private message. In general, why don't you just share it to the group so that we can all learn from each other? And the message I got was, my daughter is on methotrexate for JIA, which is juvenile idiopathic arthritis, which is among one of those others that I've written there. Will I still find this helpful? Okay. How best to answer this? So methotrexate is a typical drug used in juvenile idiopathic arthritis once steroid injections or anti-inflammatories are not helpful enough. And a percentage of people will respond and a percentage don't. Okay, and this is the same for every condition I have there. So if I was to guesstimate how effective methotrexate is in a patient who has new onset rheumatoid who comes to my rooms, it all depends how early in the disease they come. So if I'm catching the person at an early phase, let's say in the first few months, and I'm starting methotrexate, we would hazard a guess of about 50 to 60% of people would respond quite well to methotrexate. For every other disease, the percentage will be lower. Okay, to just give you an idea. Okay, I think there's a lot of questions here. Sarah, I will need your help to moderate that, but I might answer the first one by Paula.
Yeah.
Who asked how long it takes for it generally to kick in. It's quite different for everyone, but it's a slow drug. So given that it's once a week, we typically tell patients it's at least 4 weeks before you're going to have an effect, a good effect from methotrexate. But generally, rheumatologists would give up to 3 months to get a full effect of whatever dose we're using.
Cool. Okay. Rebecca's asked, why do we stay on methotrexate whilst also on Symphony? And maybe we can talk about some other medications as well.
Yeah. All right. I have a slide that will address a lot of this, but to answer your question, is that it all depends what the condition is. So particularly for rheumatoid arthritis, methotrexate seems to make every other drug work better. It's quite amazing in all the trials. So Symphony if it's being used for rheumatoid arthritis, definitely works much better with methotrexate on board. The second reason, and Simponi, for those of you who don't know, is a biologic. It's a TNF inhibitor. So it's a medicine that has been developed in a biological system that you inject, and Simponi is given, roughly once a month or once every 4 weeks. In rheumatoid arthritis, and this is not the same for every disease that it's used, but in rheumatoid arthritis, people can develop antibodies. So your body makes antibodies against the actual drug, okay, which happens to be an antibody. So how Simponi works, it's an antibody that has been designed in a lab to block a chemical called TNF, which is a very pivotal chemical, a signaling mechanism between your immune cells. And Simponi blocks this, but your own body can be smart and it creates antibodies to whack out the Simponi, and the methotrexate seems to lessen this effect. So that's why it's used. In psoriasis or psoriatic arthritis, the combined effect tends to be better for skin. And it also depends on other kind of features of the disease that you may have.
Cool. Okay. Next up, I knew there was going to be lots of questions about side effects, but Simon's asked, what impact does the long-term use of methotrexate have specifically on tendons and ligaments? And he's written that he's on injections, 25 milligrams a week, and he changed from tablets because of less side effects.
Sure. Okay, maybe if I go to the next slide, let me see. I might talk a little bit more about this, and I have definitely a full slide on side effects, and I'll try to cover all the side effects when we get to that slide, if that works for everyone else. So I wanted to give you a little bit of an idea about why rheumatologists are so keen on methotrexate. And this is actually a snapshot of a blog post that I did, I think, about 7 or 8 years ago. And I think the rheumatologists tend to use methotrexate so much because there's actually evidence for it, particularly in rheumatoid arthritis, as I said. And it's been used since the 80s, so we're all very comfortable with using it, and there's few surprises, and really the side effects that we'll get to are well known with methotrexate, okay, when you have a drug that's been around that long. Number two, it is effective in rheumatoid arthritis, less so in some of the other conditions we use it in. Remission rates have been reported about 40% mark, but that wildly depends on when a patient first presents. And just so that you appreciate this, if a person with, I suppose, any inflammatory arthritis presents early, e.g. in the first 6 months or 12 months, it is so much easier to control that disease compared to someone who presents 5, 10 years down the track, okay? Because once the immune abnormality has become quite mature, it's much harder to control it, okay? So the remission rates tend to be higher the earlier it's used. It's good in combo, okay? And what I said before when I was answering the question about Simponi is that it just seems to make every other medication work better. So common combinations with methotrexate that some of you might be on with the conventional DMARDs. Conventional DMARDs are drugs that have been around maybe 20 plus years, which are oral in nature. So the most common combination anywhere in the world would be methotrexate and Plaquenil, hydroxychloroquine, that drug that has been talked about a lot with the coronavirus. Or methotrexate and cilazopirin, or sulfasalazine is the other name for that. Or methotrexate with leflunomide. And prior to the advent of the biologics, which in Australia only became available on the PBS about 17 years ago, it was methotrexate with Plaquenil and leflunomide, or methotrexate with Plaquenil and sulfasalazine. Okay, that's a very common combination called triple therapy. Sorry, I should not say Plaquenil, I should tell you hydroxychloroquine because you're probably more familiar with that name. So that 2 or 3 drug combos are still very commonly used in other parts of the world, particularly in countries who are not as fortunate as Australia, because in Australia, we can afford to prescribe biologics, whereas in many parts, for example, in Asia, you don't have access to that. So people have to use combinations of these older drugs. It's cheap, okay? It is cheap. So I think on the PBS, you know, a year's supply of methotrexate is less than $30, right, to you guys, and it's also a cheap drug to the government. Whereas when you look at the biologics, we're talking between $10,000 and $20,000 each year. Okay, so it's quite reasonable that the government suggests that we use a cheap, you know, quite effective drug first before going to a very expensive drug. Otherwise, you know, all our taxes are going to go up, or we have to give up something else. It's convenient for most people in the oral formulation. So for most of you, what you'd be in an oral tablet, it will usually be given weekly. In Australia, there are 2.5 milligram tablets and 10 milligram tablets. I would suggest that most of you are probably on the 10 milligram tablet. So if you're on 20, it's just 2 tablets once a week. So that makes it relatively easy. And one of the reasons the rheumatologists, at least in Australia, will use it is that to even consider biologic therapy for rheumatoid arthritis and psoriatic arthritis, you need to have been on methotrexate, right? So it's like a first step to at least try it. Okay. Now, side effects. Of course, this was always going to be a very big topic. So I've got a little poll to kind of understand what you've gone through before we try to address each of those effects. So let me launch the poll. And this will be very interesting when we all kind of look at each other's answers. I'll give you a bit of time here. You don't have to choose one. You can choose as many as you've had. Because I'm anticipating there's lots here. And I don't think you're disappointing me at this point in time. There's 67 of you here, and we're up to 37 people, but it's going up very quickly. So I'm going to give you a bit of time here because I want to spend some time on this. So maybe 5 more seconds before I end the poll. Okay, let me share this. Okay. I wonder if this surprises any of you. Of course, I put this in here because these are things which are commonly talked about in my rooms. Last week, 2 weeks ago, we had a big talk about fatigue, and we mentioned that part of it could be the drug, but it is very hard to tell. Could it be the drug? Could it be the disease? And fatigue happens to be the #1 side effect being attributed to methotrexate. And, you know, it's the hardest one to fix, you know, and sometimes we just have to stop the drug to see because it's hard to know. Now, I want to point out the one below methotrexate. This is actually quite a relatively new side effect in terms of what rheumatologists have understood about this. And people talk about brain fog quite a lot. And it's something I do ask my patients. And often it's described as you can do something, but you're not doing it nearly as quickly, or you can name something, but then it's just not coming to your tongue at the right time, and then later on you remember this. Now again, whether that's due to the drug or due to the illness or due to all the other stuff that might be happening in your life, it's often very hard because chronic diseases, you know, affect every aspect of how one lives. Blood test abnormalities would probably be the most common thing, and I bet you your rheumatologist, including myself, will always be showing you your blood test because that's the one thing we are really worried about, right? And it's the one thing that's easy to track so that if there are abnormalities there, you can then dose adjust. Mouth ulcers are relatively common. It's one of the reasons we use folic acid to try to, as a vitamin B, to try to reduce that, but we also use folic acid to reduce the liver abnormalities. Hair loss is a big one. I get it. You know, no one wants hair loss, and usually it's increased hair fall. So, you know, when you comb, when you shower, there's just more there. And some people can be extremely distressed by this. And it's my practice to reduce dose straight away or dump the drug if hair loss increases, because it's always reversible. So it's not a permanent thing. So you can tell if it's due to the methotrexate. I actually think the most common thing that people, at least that report to me, are the top two. Either a bit of upset, a bit of nausea, typically not vomiting, but you just feel off on the first 24 to 48 hours after the actual pill. For many people, it's relatively mild, and if they're getting a good effect, they don't want to stop just for that. But for some people, it's terrible, and we would have to dump the tablet. Feeling unwell, sometimes it's a non-specific, I just feel washed out, or I just don't feel right for that 24 hours after. Okay, so I hope that makes sense. I'm going to stop that sharing. And at this point, I'm just going to answer, Sarah, if there were the specific questions about side effects, I might answer those then.
Yeah, there's a couple that are similar about, so whilst taking methotrexate, they experience a side effect. So the example used was tinnitus, but then they stopped methotrexate, but the side effect continued. So have you found that to be common in your patients, or how do you talk about that?
That would be really unusual. So methotrexate, the way it works, so that you guys understand, is it's given once a week. So, you know, if you can see my finger, the blood concentration goes up, and then over the next 24 or 48 hours, it goes down. And the last few days, there's not meant to be much in your system at all, because the way it works, it poisons the most rapidly dividing cells, which are the aggressive immune cells. Then there's this drop. We're not giving it daily because we want your normal cells to not be affected and to kind of recover if they are in some way. So once you stop taking methotrexate, the actual effect should dissipate relatively quickly in the first few weeks. And then all the metabolites are things where when methotrexate gets broken down, they are chemicals which last a bit longer. And really by 6 to 8 weeks, they should all be out of your system. If any of you have been told to wait 3 months before you fall pregnant, that's because we just want to be extra safe, obviously with something like pregnancy. So we typically say wait 3 months before you try to have a baby once you stop methotrexate. So if the tinnitus continues, it just becomes a bit harder to understand, to blame it on methotrexate. And you know, usually I look at other drugs as well, or, you know, you need to get assessment by a ENT surgeon. But tinnitus is also, unfortunately, a relatively common symptom. So that's a hard one.
Okay, what about folate? So Katrina's asked, she's expressed that she gets very sick after taking the folate, hence often doesn't take them. Are there long-term side effects of not taking the folate whilst taking methotrexate?
Yeah, so folic acid is a good to have. So there are many trials showing that folic acid reduces side effects. So that's kind of clear. We all think it reduces different side effects, but the best trials have shown definitely liver test abnormalities. So that's why we want it. But if your diet actually has lots of folic acid, so you eat plenty of green vegetables, you eat fresh fruit and veggies, you should have lots of folic acid anyway. But, you know, for a cheap medicine that typically is very well tolerated, that's why we give it. So if you can't tolerate it, you should just, you know, eat fresh vegetables and fruit, and you should get your folic acid that way. The other thing you can do is if there are liver test abnormalities, for example, any side effects, is there's a different form of folic acid called folinic acid. It's much more expensive, but it's a powerful form of folic acid that can be used as well. But if you were sick, I wouldn't make you take folic acid, particularly if you don't have side effects that are methotrexate and the liver tests are all fine.
Cool. Okay. I'm quite interested in the answer to this question. So Lucy's been taking methotrexate for a number of years, and her hair's now affected, very thin. So are you aware of anything that will actually help people improve things with regard to their hair?
Yeah, so different patients of mine have actually gone and tried different things, and I don't have anything to particularly suggest because everyone's quite different, but there are patients who've tried various shampoos that they found through the net and thought it was useful. One of the difficulties I have to blame thinning is that if you were on methotrexate and weren't well controlled, you may have needed other medicines. So for example, prednisone. And prednisone is very commonly causes hair changes. You can have fine, thin hair on the face, extra hair all around different parts of your body. Some people will say that their hair becomes coarse, others will say that it becomes thin. So I know once someone's placed on methotrexate, the difficulty is that the side effect is always blamed on methotrexate. But there are other things, because unfortunately most people are not just on one medicine. But yes, I'm sorry, I don't have a specific antidote to it, to the hair thinning.
And still...
Oh, sorry, can I just answer that in another way? We would also usually, just as in fatigue, you would have to think of other things. And hopefully your GP would have screened for iron, making sure you have enough B12, even your calcium, vitamin D, phosphate. So you need all the basics done as well for hair thinning. But yeah, if there isn't anything else, then you try different shampoos, different things.
So thanks for watching. I hope you found that video helpful. If you'd like to see the rest of that topic, then please consider joining BJC Connect. It's our online platform where we upload all of the resources and the educational events that we run. It's free to set up, and then you can watch the rest of the video whenever suits you. The link for that and how you actually do that is just below. Also, if you like our content and you want to see more of it, then please like our channel or subscribe to it, and we look forward to seeing you soon.